Welcome to another Persiflager's podcast. Review the infectious disease literature with commentary for the first 2 weeks of April 2008. Remember, if you're sick of this intro, you can skip ahead to the next chapter. This is the second time I have recorded this podcast because the first time the program I was using trashed everything. So, my son's in the background playing basketball on his spring break, and you can listen to him shoot some hoops while I go through this podcast. Remember, this is on iTunes, so if you like it, go write me a review on iTunes and tell the world what a wonderful human being I am.
He's a wonderful human being.
Brought to you by Puscast LLC, publisher of the Persiflager's annotated compendium of infectious facts, dogma, and opinion, your uber-hyperlinked electronic guide to infectious diseases at Puscast.com. All the opinions are those of Mark Crislip and Puscast LLC. Since it's CME accredited, I need to mention my conflicts of interest. I don't have any, but I desperately would like some conflicts of interest. So, if there's anybody out there who wants me to ghostwrite their research, I'd be happy to do it for a small fee. See this month's JAMA if you wonder what I'm talking about. And then once you've listened, take the online quiz and get a half an hour of free CME thanks to Legacy Health Systems. To finish up with the usual business, it's not called Persiflagers for nothing. This podcast will contain snide comments and sarcastic asides, so don't say I didn't warn you. Don't forget the Legacy Health System residency program. If they can tolerate me, they can probably tolerate you. And don't forget the Infectious Disease ID Wiki, currently languishing in obscurity, but just awaiting your work to make it a world-class infectious disease textbook. And then don't forget my Quackcast, an occasional review of skeptical, complementary, and alternative medicine, now also on iTunes. A special shout out. Hey, am I cool or what? I can say the word shout out to those who have paid for this podcast. Thank you very much. It keeps the bandwidth up and running. And if you like this podcast, please do not download all of the podcasts at once, as it puts quite a strain on my bandwidth. And if you've ever had a strained bandwidth, you'll know what I'm talking about. So now, on to the literature. So the B-52s did a song called Rock Lobster, and there's nothing that'll turn you redder than lobster in water. But also, there's also B-5701, which is slightly different than the B-52s, but that's the HLA type that predicts hypersensitivity to abacavir. There's been multiple studies out about this of late. This one also looked at the sensitivity and specificity of the HLA B5701 in predicting hypersensitivity reaction to abacavir in both whites and blacks. HLA B5701 is less common in African Americans in both blacks and whites if you had an immunologically documented hypersensitivity to abacavir. This was both a clinical syndrome plus patch testing. There was a 100% likelihood that you had HLA B5701. Now, if you're in a resource-rich country, which is not the United States anymore, we're second to none because I think we're 37th. You can test for HLA B5701 before you start abacavir and know that they're at higher risk for susceptibility reaction, although not everybody with that HLA type will get a hypersensitivity reaction to abacavir. And the next time you listen to the B-52s and think of rock lobster, think of abacavir hypersensitivity reactions. As an aside, last podcast we talked about HLA subtype diversity and progression of disease. This week's New England Journal of Medicine has an extremely detailed review of the meaning of subtype in HIV and disease progression and development of resistance to HIV therapy. So if your Unisom is not working, check it out. Next up with HIV is trichomonas. This study looked at repeated trichomonas infections in HIV positive versus HIV negative women and found that if you were having recurrent trichomonas infections, you were more likely to be sexually active. Next up, water is wet, fire is hot. But the more interesting thing from this study is the patients who failed. In these studies, everybody with the trichomonas was observed to take 2 grams of metronidazole, and their failure rate was about 55% in these studies, being HIV negative or HIV positive. And this may be due to the fact that the strains that failed therapy were slightly resistant to metronidazole. So we may be seeing an increase in resistance in trichomonas in the community. I had a patient once with a trick knee. Now we have a trick. Hi there, did you miss me? I'm back from the Jackie Chan movie with my 10-year-old. The Forbidden Kingdom. A lot of fun if you like kung fu movies. This one is an article that proves I cannot pronounce antibiotics. This was an article published in Clinical Infectious Diseases that looked at children being treated for malaria and whether or not they were HIV positive or not, and whether or not they were on antiretrovirals or not. Those that were HIV positive were more likely to develop neutropenia, and those who were on HAART were even more likely to go on to develop significant life-threatening neutropenia. What is this treatment, you ask? It's artemisate, ARTESUNATE, plus amiodarquine, AMODIAQUINE. So this was a treatment of uncomplicated malaria in HIV-infected children. 45% of the children with HIV developed neutropenia, as opposed to 6% of them what didn't have it. And if they were on HAART, 75% of those developed neutropenia versus 26% of the HIV non-HAART children receiving the unpronounceable therapy for their malaria of artesunate and amodiaquone. I'm sure I pronounced both of those wrong. Floss and brush. We've talked in other podcasts. It's now the royal we have talked about the importance of periodontitis as a cause of systemic inflammation. And we have talked about HPV as a cause of head and neck carcinoma. Well, it turns out that if you have HPV 18 and you have periodontitis, your chance of tongue cancer goes up, and there's a disease you don't want resected. Now, this study only had 30 patients, so it wasn't like it was huge, but of the patients who had tongue cancer and were HPV positive, 90% also had periodontitis, versus 79 patients who are HPV negative tumors who did not have periodontitis. So it would appear that periodontitis, as judged by radiographic loss of alveolar bone in the jaw, is a synergistic effect for the development of HPV, mostly 16 related cancers. My son's high school's animal mascot is the aardvark. Man. And now I shouldn't complain, though, because I'm a University of Oregon grad, and the mascot is the fighting ducks. Really terrifying, huh? Well, actually, it may be more terrifying in the future, because how is avian influenza likely to get to North and South America? It's unlikely that the people who get avian influenza are going to spread it, and chickens are not transported back and forth across the oceans like they are on the other side of the world. So the duck is a likely candidate. Why would the duck be responsible for avian influenza? Well, they tend to fly north-south long ways as a result of migration. And at the North Pole, they will meet with ducks from the other parts of the world, such as Asia and India and Africa, where there is avian influenza. And it turns out that the duck is particularly resistant to dying from influenza. They can be highly infected and have large amounts of avian flu in their urine, yet not be sick. They did this test, and it was published in Emerging Infections, where they took wild ducks and experimentally infected them. And it turned out that the tufted duck, the Eurasian pochard, and the mallard of all things, excreted large amounts of avian influenza, but it did not kill them. As a lecturer said at one of our lectures, there's no defense against the duck. Now, at the time, I took it in terms of University of Oregon basketball, but now I guess that would be a reference to migratory ducks. So I guess the real enemy is Ducks Unlimited, and the first cases of avian influenza that hit the North and South America may be in people who hunt or keep wild ducks. So keep an eye out. If Donald gets sick, if Daffy gets goofy, which would cross movie studios, then think about avian influenza. BTW, see, I'm pretty good at text message speak. Like HIV talked about earlier, avian influenza is also mutating and changing as it goes, and different clades of the virus are taking the place of other clades throughout Southeast Asia. So the virus that's present now is not the same one that was present at the beginning of the epidemic. my son and I just watched I Am Legend, so hopefully Will Smith is hard at work on a cure for this particular virus. And if he's not working on influenza virus, I hope he's in the European Union right now working on blue tongue. I just happen to like the name of this virus, so I'm mentioning the fact that since 1998, Western Europe has been having an outbreak of blue tongue disease, which has not been seen in that country except sporadically in the past. Blue tongue is an infectious virus in the family of the Reoviridae, and in case you're interested, the genus Orbivirus, named after Roy Orbison. It makes all the viruses quite lonely, but it causes the tongue to turn blue in the animals because they get so cyanotic. Now, I've never seen a blue tongue in a human, but you have to be pretty cyanotic if you're a cow and you're turning blue. I used to think that cats were the worst vermin for giving infections to human beings, but maybe I should rethink that and blame swine. Insert your own favorite profession here. We talked recently how strep suis is the most common cause of meningitis now in Vietnam. And now there's the Nipah NIPAH virus. Initially reported in Malaysia and Singapore, there's now an outbreak in Bangladesh, and this disease has between a 40 and, in this series, 73% mortality rate. This particular virus is almost always associated with people who raised and dealt with pigs for a living. They present initially with fevers, a ARDS syndrome, get convulsions and coma, altered mental status, and die. It's not a good virus. The Nipah virus, in case you're interested, is a paramyxovirus that is closely related to the Hendra virus, which was named after the comedian Tony Hendra. An obscure reference at best. There is no Nipah virus in the North American or South American area that I can find, but pigs tend to travel, so I would expect that someday the Nipah virus will end up in the United States as well. Remember that the trade in illegal animals generates more income than trade in illegal drugs. Just imagine how much money you could make if you were using illegal animals as an illegal drug. This next paper is a good illustration of how cool infectious diseases is and why other fields can't hold a candle to infectious diseases. Now, cowpox is still around. It's related to the other orthopox viruses like smallpox and monkeypox. It's seen in the old world and is found primarily in wild rodents, which serve as a natural reservoir in Europe. So get this. In England, specifically in northern Germany, this poor elephant comes in with this widespread disseminated ulcerative lesions, and it dies. So they look at it, and it's cowpox. And then they check out its owner, who goes on to develop cowpox. So they look at the rodents in the area where the animal was being raised, and the rodents had the same strain of cowpox. So this cowpox went from local rats to a circus elephant to human beings. Now, I've been keeping a pet elephant in my basement for years now, and I think it's going to be important that I check out the local rats for the presence of cowpox. But where at other field are you going to see the spread of a disease from a rat to an elephant to a human? Certainly not in cardiology or pathology. I'm amazed that after almost 25 years in infectious diseases, of things that I never thought about or had to consider in my practice. Now, as you know, if you get chemotherapy, it suppresses your immune system. If you happen to be hepatitis B surface antigen positive, your hepatitis B is likely to go bananas, lyse your liver, and kill you. So can you do anything about it? But of course, the Annals has a systematic review of the use of lamivudine to prevent hepatitis B reactivation during chemotherapy. They looked at 14 different trials of patients who had lamivudine or nothing when they got chemo who were hepatitis B surface antigen positive. The results of this meta-analysis, you ask? Quote, none of the patients in the preventative lamivudine group developed hepatitis B-related hepatic failure, 0 of 108 versus 21 of 162 patients, and only 4 deaths were attributable to HPV, 4 of 208 versus 27 of 394 patients. So it would appear that lamivudine is not only well tolerated with no adverse effects, as they mention in the systemic review, but also it seems to be effective in preventing the acute hepatitis B reactivation in patients who are hepatitis B surface antigen positive who are getting chemo. Now, of course, hopefully the hepatitis B vaccine will make this a disease of the past. There's been an outbreak of mumps in the United States. In 2006, there were 6,584 cases of mumps reported, and these all occurred in people who had the vaccine. The vaccine failure rate, even in people who had both MMWRs as is recommended. So while they got their vaccine as they should have in childhood, when they hit their college age years, they developed vaccine failure and subsequent mumps. Bummer. Now, why would this be? Well, though the review of the outbreak was reported in the New England Journal of Medicine, there was an article in Clinical Infectious Diseases that looked at the persistence of antibody in patients who received the MMWR at 20 years. It turns out that even if you got both your MMWRs as required, your measles antibody rates were 95%, your rubella antibody rates were 100%, but your mumps was a paltry 74%. So 20 years after you get the mumps vaccine, a quarter of people will no longer have protective antibody to the MMWR. So not only do we need a good 5-cent cigar and a chicken in every pot, but we probably need a better mumps vaccine. And hopefully the next vaccine with mumps in it will have better nano-tracking devices. I only mention this because I'm bitter. Once upon a time, there was a board question, and this board question concerned antibiotic prophylaxis. The patients were on penicillin prophylaxis to prevent rheumatic disease and needed to have dental work done. Should they get a penicillin? The answer from the ACP was no, that they should have resistant viridin strep in their mouth because of the chronic penicillin exposure. Well, that turns out not to be true. There's a study that was done in children who got IM monthly penicillin for rheumatic fever prophylaxis, and they found that the viridin strep in their mouth had no alteration in their MICs to penicillin as judged by e-test. So the monthly use of penicillin was not increasing the MIC to penicillin, so penicillin should be a sufficient drug for prophylaxis in that patient population. The ACP owes me a question point. I got it right. They were wrong. Here's the data. Ha! So my son wants to know if Mad Magazine is sold out compared to how it used to be back in the day. I say no. If you want to send me an email, let me know. Has Mad Magazine sold out? Now, the other question is, does colonization precede infection? Well, when it comes to VRE, the answer in this study shows yeah, but at a fairly small rate. This study looked at 768 patients who were colonized with VRE, and they found that 31 or 4% eventually developed VRE in their bloodstream, infections that won't be paid for come October. Now, the independent risk factors for developing a bloodstream infection were admission to the hospital from a long-term care facility and, not unsurprisingly, receipt of vancomycin. Give vancomycin, it overgrows, you get bacteremic. So does colonization precede infection when it comes to VRE? Well, I don't know what the rates are, but certainly if you get it, your chance of in your stool, your chance of getting in your blood is about 4%. Even worse than VRE in your blood, of course, is MRSA in your blood. What are your chances of getting MRSA if you become newly colonized with that organism? By the way, it's MRSA, not MRSA. This was a meta-analysis that was published in the American Journal of Medicine that looked at 10 observational studies with about 1,200 patients. And they figured that if you become newly colonized with MRSA, your chance of developing an infection is about 4-fold, which is pretty good. What to do about new colonization and how to eradicate staph and whether or not you should be doing ongoing screening for MRSA are questions that still are not as clear-cut as one would like. Certainly, active screening is probably soon to be the way of looking for MRSA, and it's probably reasonable that if you get a new culture for someone who's colonized with MRSA, that it's reasonable to try and eradicate it with some combination of antibiotics and topical decontamination, though that does not include putting the patient in the autoclave, which is probably the only thing that fundamentally will work. The following article is probably the most important one I'm going to talk about this month, and that is, what do you do about Staph aureus bacteremia? This study looked at the impact of having an infectious disease consultation on Staph bacteremia. They compared 134 patients over a year's time, during which there was no mandatory ID consultation for Staph bacteremia, and compared that to 100 patients over a year's time when it was mandated to get a infectious disease consultation. And guess what? The self-serving infectious disease doctors found that upon reviewing the charts, the patients who had ID consults had more appropriate use of studies and also had better medical care as judged by repeat blood cultures and a use of appropriate antibiotics. And they also had a smaller, although not statistically significant, death rate. So, if you have a patient with Staph bacteremia, call your ID doctor. You and your patients will benefit, as will the ID doc, because he can make some money. I've always been fairly sanguine about C. difficile diarrhea, that it was a very unusual cause of community-acquired diarrhea. Now, back on the East Coast, they are having an outbreak of a hyper-producing strain of C. diff, and because of this, they started doing surveillance of diarrhea in Connecticut, which should be pronounced Connecticut. And they found that it was not unusual to have C. difficile diarrhea in the outpatient setting. My son, as you can see, loves the word diarrhea. They found 241 cases when they were looking for C. difficile in Connecticut in 2006, which makes it a rate of about 7 per 100,000 population. So this would make community-acquired C. difficile in patients with an absence of risk factors, i.e. patients who get C. difficile for no damn good reason, to be fairly common as a cause of diarrhea. So if you have someone who comes in with the bloody Hershey squirts, think about C. difficile, even if they've not been on antibiotics and not been in a healthcare environment. And maybe, just maybe, if your travel plans are taking you to Connecticut this year, maybe you want to go to a different state. And also, if you're going to get your knee replaced, you may not want to do it in Barcelona, Spain, where they did this study. Now, the issue is prophylactic antibiotics at the time of knee replacement. You want to give your antibiotic 30 to 60 minutes before cut time so that you have maximal antibiotic in your tissues before you do your knee replacement. There's a problem with the knee surgery is that they put a tourniquet on the knee, depriving blood and therefore antibiotics to the knee area. So perhaps it would be a good idea to give the prophylactic antibiotic at the time they do a letdown of the tourniquet. So this is what they did in Barcelona, and they found that the infection rates were the same whether or not the antibiotics were given 30 to 60 minutes before cut time or the antibiotics were given at the time of tourniquet letdown. Both patient populations also received a second dose of antibiotics 6 hours after the surgical procedure. Now, why do I say you don't want to go to Spain for your surgery? If you had standard therapy, your infection rate at 3 months was 3.4%, and at 12 months, it was 3.6%. If you had the experimental therapy, it was 1.9% at 3 months and 2.6% at 12 months. But 3 months into it, they were having a 3% surgical infection rate, which is a whopping high compared to what's usually reported for a knee replacement. Now, it is interesting that it was not statistically significant, but at both 3 months and 12 months, the group that received their antibiotic at the time of the tourniquet letdown had a lesser infection rate. So there may be something to that. They say it's non-inferior, and they only had about 450 patients in each group. So the study was probably not powered to show a small difference in the two groups. But it is suggestive that A, you don't want to have your knee replacement in Spain, and B, it may be a good thing to get your antibiotic dose at the time of tourniquet letdown. Maybe. For good or ill, I've always been primitive about the approach to the diabetic foot infection. I think that if you have osteomyelitis, you cut out the osteo. If you cut out the osteo, you cure it. You don't need further antibiotics. And if you treat them with long-term antibiotics without debridement, that is the OED definition of futility. Well, maybe not so much so. This study looked at 50 patients in Spain with diabetic osteo of either the small bones or the metatarsal heads, and they did bone biopsies. And then they gave antibiotics directed against the organisms found on the bone biopsy. They didn't whack the whole bone out. They just took a little piece of it. And by doing that, they found that at the end of a year, 64% of patients were in remission for their osteomyelitis. So maybe it is not absolutely mandated that you whack out the small bones and metatarsals in diabetic osteomyelitis. But certainly if you're going to treat these patients with a long-term course of antibiotics, and in this study they had an average of 12 weeks of antibiotics, that you need to do bone cultures first and not just randomly give antibiotics based upon the cultures of the diabetic foot ulcer. Remember that the microbiology of the diabetic foot ulcer is just an extension of the patient's butt. Now, inflammation is a bad thing. Patients with pneumonias are more likely to have a myocardial infarction. Patients with cystitis are more likely to develop a DVT. And so, why is this? And is there anything you can do about it? This study is not of clinical relevance, but I think is interesting because they measured the blood levels of patients who survived community-acquired pneumonias looking at specific mediators of inflammation. In this case, it was IL-6 and IL-10. And they found patients who had elevated levels at IL-6 and IL-10 were much more likely to die in the next year than those who had low levels. Now, these were all patients who were doing well clinically. They met the usual criteria for being discharged home with their pneumonia, but at the time that they were discharged, unbeknownst to both the doctors and the patients, they had high levels that were markers of inflammation and subsequently an increased risk of death. So, inflammation, i.e. boosting your immune system, is again a bad thing. In this case, if your immune system is being boosted by a community-acquired pneumonia. Someday, if the healthcare system in the country is not bankrupt by futile wars, perhaps we'll be measuring these types of inflammatory markers on patients at the time of discharge as a way of trying to figure out who is at increased risk of death. However, patients who die are cheaper for the healthcare system, so I doubt we'll do this in the long run. Welcome to National Meta-Analysis Week. This is another meta-analysis published this month, this one in the Annals of Internal Medicine. And they looked at antibiotics for prophylaxis against hemodialysis catheter-related infection. They had a grand total of 16 trials that had only about a 6-month follow-up. But they found that both topical and intraluminal antibiotics were beneficial in decreasing both the rates of bacteremia and the need for catheter removal in patients with hemodialysis catheters. They state whether, quote, these strategies will lead to antimicrobial resistance and loss of efficacy over longer periods of time remains unclear, end quote. Despite my harping on the penicillin and rheumatic fever study earlier in this podcast, certainly the use of antibiotics always eventually leads to resistance. So one would anticipate that topical and intraluminal antibiotics will lead to antibiotic resistance in this patient population. I think it's better to do an alcohol lock where the patient gets 25% alcohol in the lumen of their catheter for about half an hour, although the studies for that are currently pending. And then if there's a little alcohol left over, then the dialysis unit can have a little party. Just joking, should the Oregon Board of Medical Examiners be listening. The tried and true method for determining if a catheter is infected is the Mackey method. In the Mackey method, you yank out the catheter, you cut off the tip, you roll it on auger, and you count the number of colonies. And if there's a certain number of colonies, you call the catheter infected. Now, these are always incubated aerobically and never anaerobically. This study actually did the Mackey method and incubated the plates anaerobically, and they found Propionibacterium acnes in 15% of the positive cultures. Makes you wonder if some of these fevers that get better when you pull catheters are due to Propionibacterium acnes. This is an anaerobic gram-positive rod that loves to cause infections associated with prosthetic materials, such as fracture sites and craniotomies. It grows in the base of hair follicles. So if you have a furry male who has a fever and a catheter, well, maybe we should be checking these catheters for P. acnes as well. Whether you should have empiric therapy, etc., is as of yet unworked out, and I'm sure that local mileage will vary as to whether or not P. acnes is found on the catheters, but a very interesting and suggestive study. One of my long rule of thumbs is never to read a journal article with an enzyme in the title, but this one is the exception that disproves the rule. Pyruvate kinase, to quote from the New England Journal article, catalyzes the rate-limiting step of glycolysis, converting phosphoenol pyruvate to pyruvate with the generation of one molecule of ATP. In the absence of mitochondria, which are lacking in mature erythrocytes, the enzyme is critical to energy production. Why would you care about this? Well, it turns out that if humans have pyruvate kinase deficiency, which is the second most common erythrocyte enzyme disorder, their erythrocytes are protected from getting Falciparum malariae. The malaria has increased trouble getting into these red cells, and there's increased clearance of these red cells. Now, there has been no organism that has had more impact on human genetic evolution than malaria. We all know about sickle cell, but there are multiple other red cell genetic anomalies that are due to the human interaction with malaria over millennia. Say that 3 times real fast. This is another one to add to the growing list of genetic alterations due to the human interactions with malaria. I'm an ID doc. Infectious diseases, not intelligent design. And to be an ID doc is to truly appreciate the beauty of evolution and its impact on human beings and the development of infectious diseases. So, yippee skippy, we're at the end of another Puscast, the Persiflager's Infectious Disease podcast, to review the infectious disease literature with commentary, this one covering April 1 through 15, 2008. References, including some not mentioned in the podcast, are available on the website. This is CME accredited. Now that you've listened to my babbling, take the online quiz and get a half an hour of free CME thanks to Legacy Health Systems. Brought to you as always by Pusware LLC, the publisher of the Persiflager's Annotated Compendium of Infectious Disease Facts, Dogma, and Opinion, your uber hyperlinked electronic guide to infectious diseases at pusware.com. Don't forget, if you like this, to go to iTunes and write me a glowing review. Don't forget my podcast, Quackcast, a review of alternative medicine, such as it is, and I'm also an occasional blogger on the science-based medicine blog. Remember that there's also the Infectious Diseases Wiki languishing in obscurity as I try and generate a world-class infectious disease textbook with your help. Well, no one's helping, with my help. Bandwidth ain't free, so feel free to purchase the compendium and support the podcast. This is copyright with Creative Commons license. The music is by my eldest son when he was 12. He's now 14, improvising on the guitar. Feel free to send comments at mcrislip@pusware.com. And as always, thank you for this most interesting consultation, allowing me to participate in the care of this most difficult and challenging case. I will continue to follow along with you. Thank you. In dictation, goodbye.